Here are my disclosures. As many of you know, in 1932, Dr. Harvey Cushing described the presence of small basophilic pituitary tumors in patients with the signs and symptoms we now acknowledge or recognize as cortisol excess. But his first patient, the index case of this disorder, presented to his office when he was at Hopkins in Baltimore, well over 100 years ago, the famous mini G with obesity, hirsutism, hypertension, and secondary amenorrhea. My interest in this really began at the General Medicine Clinic at Milwaukee County Hospital in September of 1977, and I had went in to see a new patient, a woman with truncal obesity, hypertension, diabetes, and elevated cholesterol. And I went to my attending physician and said, well, could she have Cushing's syndrome? Well, many of you who were trained in the 70s or 60s or 70s remember that humiliation was allowed in those days, and it was very common for attending staff to try to humiliate residents. Of course, residents try to humiliate medical students. He says, no, it's rare. Testing is very difficult, and you could always tell on examination. So that's a stupid question. So was this a stupid question? And it really motivated me to start investigating whether patients like this might have Cushing's syndrome. And that passion really got amplified the next month when I did a endocrinology rotation with Jim Cerletti, and I don't think he needs any introduction to this audience. He was really the reason I became an endocrinologist and became obviously a friend and as well as a mentor. So the diagnosis of Cushing's syndrome in 1977, well, we knew that there were ACTH secreting tumors, either in the pituitary or ectopic, that adrenal nodule disease was present, an adenoma and carcinoma. But the testing for this was really barbaric by today's standards. I mean, we did 2-day, the patients usually were hospitalized with low-dose dexamethasone suppression. We measured something called 7-hydroxycorticosteroids, which of course is not done any longer. Then it was followed by a 2-day higher dose, 2 milligrams every 6 hours, dexamethasone suppression test. There was the overnight 1 milligram dexamethasone suppression test, which is still in use and which I'll mention briefly. But the only imaging study was an X-ray of the sella. I mean, think about this for a few minutes. There was no CT or MRI, and urine cortisol and plasma ACTH could not be measured. This is 1977. Well, the following spring in 1978, this article appeared in the New England Journal of Medicine, which was the first time that transmural pituitary surgery was reported as removing these small pituitary tumors that Dr. Cushing had mentioned with resolution of the hypercortisolism. And I saw this article and I said, I'm going to San Francisco. This is where these guys are on the cutting edge. This is where I want to go. And fortunately, I got invited to be a fellow there. And it turns out that that 4 of the first 50 patients they operated on for Cushing's didn't have pituitary tumor. So a little less than 10% had something else. They did not have a pituitary tumor and did not go into remission. And the man who is really I think would arguably the greatest pituitary neurosurgeon of the 20th century, Charlie Wilson, I had the pleasure to work with and watch him operate. This article appeared in the New Yorker. It's Malcolm Gladwell, so many of you probably are familiar with some of his work. It's an article called The Physical Genius, published in 1999, and he compared Dr. Wilson to Wayne Gretzky and Yo-Yo Ma, and what they have in common is some kind of physical genius. And Dr. Wilson said his surgical prowess he didn't really fully understand. It was as if he had an invisible hand. So I think people who have physical genius sometimes don't really understand themselves why they have this. But it was really a great honor to work with Dr. Wilson. And this is what he operated on people's pituitary with Cushing's based on this, an X-ray of the cella. There was no CT or MRI in the late 70s. So recognizing that many of these patients didn't have pituitary tumors, that and with the full understanding that ectopic production of ACTH, usually from lung tumors, was common, we needed to find a better test to distinguish pituitary ACTH screening tumors from those that were not in the pituitary. And I'll get to some of the other tests, some of the hormonal tests we did, like dexamethasone suppression testing, in a minute, but it became clear that those tests were very valuable, and we needed a more robust way to make this distinction. And I was fortunate to work with Dave Norman in the radiology at UCSF. I don't have a little robot, and I wish I would have learned to do this procedure, because I'm sure you get paid a lot more to do it than you do to order it. But catheters are placed in the inferior petrosal sinus. Anterior pituitary hormones reach the systemic circulation into the cavernous sinus, and then the inferior petrosal sinus and the jugular bulb and jugular vein. And actually, I started this project to prove this didn't work, because I knew there would be a lot of venous admixture in the jugular bulb and jugular vein, but I didn't know about the inferior petrosal sinus. And when I learned about that, I realized that that might be valuable. And it turned out that it was. And our first report was actually 40 years ago, showing that venous sampling from the inferior petrosal sinus distinguished pituitary Cushing's from ectopic Cushing's. And this is the kind of the first report. We didn't have very, obviously, I don't think this would ever get published now with only 9 patients. Shows you how things have changed. But 6 patients had central to peripheral ACTH ratios, that is central petrosal sinus to peripheral, in the much greater than 2, and jugular bulb and jugular vein were a little better than ectopics, but not much. So there's a lot of, they didn't really distinguish ectopics. So you really needed to be in the petrosal sinus. And we had 3 patients with ectopic that did not have a gradient. Well, this study has become a lot more sophisticated than it was in 1981. The next person I met in San Francisco was Dr. Satoshi Hain, and Sats was ran our laboratory, and he taught me how to do immunoassay for both ACTH and cortisol. And Sats was a Japanese American who grew up in California. And at the start of World War II, of course, a lot of Japanese, including Sats's family, were put in an internment camp. And he spent his late teens in this camp. And as soon as the war ended, the United States government drafted him. What a great country. And instead of he avoided the draft, somehow ended up at the University of Chicago, got a PhD, and did his postdoc at Stanford. And at Stanford, he studied Pacific salmon as they begin their fluvial migration up the Sacramento River. And I think many of you who have seen salmon go up the river. So for example, the Sheboygan River, when I play golf up there, I sometimes see them going up to spawn. I mean, it's stressful. It is very stressful. And they get high corticosteroid levels and develop features of cortisol excess with cutaneous wasting, redistribution of fat into the central compartment, and due to the immunosuppressive effects of cortisol excess, superficial fungal infections. So this taught me that in life, that cortisol excess, regardless of whether it's from a pathologic neoplastic cause or from some physiologic non-neoplastic cause, the physical features may be quite similar. And this is a lesson that I'll talk about more in the future. The other person I met at UCSF, and who has been my collaborator and friend and for many, many years now is Dr. Herschel Raff, who I'm sure many of you know. Herschel was a postdoc in Mary Dahlman's lab there, and they did a lot of research on pituitary adrenal function, and I used to go over to the lab, and we used to talk about the HPA axis. And somehow I got Herschel to come to Milwaukee after I got here, and he set up a lab and has received numerous extramural grants, including many NIH grants. One of the first clinical projects we did when he got to Milwaukee was measurement of plasma ACTH. Plasma ACTH was not an easy assay in those days, and not very precise, and certainly not very sensitive. And then the Nichols Institute, we were fortunate, set up something called an immunometric assay. What this was the first really reliable ACTH assay. And what they did is they had two antibodies, one at the amino terminal, one at the carboxy terminal end of the ACTH molecule. Of course, they use radioactive iodine, and in those days, of course, we don't use radioactive material anymore for this, and use biotin. And when this antibody from these two antibodies connected to cause a sandwich, and then connect to this avidity-coated bead with biotin, and you could get a direct measurement of ACTH. And it was a very reliable assay that we published obviously over 30 years ago. So this was really the first. Now there have, of course, been many changes in this, some of them not so good, as I'll show you in a minute. And then we took this assay and, of course, utilized it in petrosal sinus sampling. And we showed, and now that we needed to use CRH as stimulation. We use DDAVP now because CRH doesn't exist anymore in the United States, to stimulate ACTH. And we could distinguish patients with pituitary Cushing's from ectopic with great reliability. And this became really the gold standard for the differential diagnosis of Cushing's. Prior to even sophisticated MRI, and even with pituitary MRI now, 30 to 40% of patients have normal pituitary MRIs with small ACTH screening tumors. So this procedure, although not done as frequently as it was done in probably the 80s, still is done pretty frequently at our institution. Subsequently, we learned that you needed to have a surrogate of pituitary venous effluent, that somehow you needed a denominator in some patients because their ACTH secretion from the pituitary wasn't very robust, or they had aberrant pituitary venous drainage. And we were the first to describe prolactin as a means of kind of assessing the integrity of the sampling procedure. This is sort of similar to for the endocrinologist. We use cortisol when we do aldosterone sampling for primary aldosteronism from the adrenal veins. We use cortisol as a denominator. And now with this procedure, in many patients, we have to use prolactin as a denominator to get satisfactory results. So that was kind of a thing that changed this procedure. So, and we're very fortunate at our institution, MCW at Frederick, we have Mark Lazzaro, who does this procedure and is certainly one of the best people, I think, in the country doing it now. And then just a couple years ago, well, actually more than 2 years ago, actually 4 or 5 years ago, we began to realize that some of the ACTH assays and some were not very accurate. And we've discovered with the Mayo Clinic, this is Mayo Clinic, and Lauren Green from Sinai in New York, and a couple other groups in us, and reported 17 patients who had erroneously diagnosed using a ACTH assay called Emulitis, a Siemens platform. It turned out to be just a corrupt assay. And we had 7 patients with ACTH-dependent Cushing's, that's out with this assay, who actually had adrenal Cushing's, which had really low ACTH levels. 6 patients who had Cushing's disease, one of whom had unnecessary surgery, didn't have Cushing's syndrome at all, and 3 patients had incorrect assessment of adrenal insufficiency. So this really sort of fundamentally changed how research labs do ACTH measurements now. And this assay, with the exception of one reference lab, has been abandoned. Now, dexamethasone suppression testing, any of you who know anything about this have probably heard about this test. It's been around a long time. It started at Vanderbilt with Grant Little. again, I mentioned the dexamethasone low dose and high dose testing. And then UCSF, where I trained, of course, in 1963, they developed the overnight 1 milligram test. Now, the amazing thing is, I mean, in what specialty can you think of a test that was developed in 1963 that's still widely used? Not many. And here is the initial report in JAMA. Now, here, what's so interesting about this is look what they measured: plasma 17-hydroxycorticosteroids, cortisoval chromogens. I mean, don't ask me what that is. It's a compilation of all sorts of probably steroids, not just cortisol. And they decided that patients in controls were almost always less than 5 micrograms per deciliter, and patients with Cushing's syndrome were much higher. And this 5 micrograms per deciliter, this is 1965 is when this was published. That stuck for years. I mean, you cannot believe people think this 5 was some kind of magic thing, and they weren't even measuring cortisol. They were measuring a lot more than cortisol. But that stuck around for a long time until about the 90s. And we began to realize that there are a lot of people whose dexamethasone cortisol level after dexamethasone was less than 5 who had proven Cushing's disease. And these are 73 patients we studied back then. And we found at least 15 out of these 73 patients who had, or 12, I guess, about 12 patients who had cortisol levels less than 5 who had proven pituitary Cushing's. So because of this study and others, we weren't the only ones that, of course, demonstrated this, the criteria for the dexamethasone suppression test has changed in the early 2000s. And this just illustrates that the plasma cortisol after dexamethasone correlates pretty well with the urine-free cortisol. That is, the greater the magnitude of cortisol excess, the less likely they are to suppress. But patients who have not very high urine cortisols are likely to suppress. So I think this was not a big surprise or revelation, but certainly changed the criteria of dexamethasone suppression testing. Now everyone in all guidelines and many consensus groups of pathologists and endocrinologists, anybody else who's interested, now use 1.8 as the threshold after dexamethasone, or 50 nanomolar. And I think everyone sort of agrees with this number now. Now, the high dose dexamethasone suppression testing was flawed from the beginning, but that's another story. But the idea was that since we did before petrosal sinus sampling, they thought, well, if you give high doses of dexamethasone, people with Cushing's disease will suppress, and patients with ectopic won't. And so everybody knew that the urine cortisol and Cushing's disease and ectopic pretty much overlap. Ectopics tend to be higher, but there's a lot of overlap. Same with the plasma ACTH values. But if you did suppression, that could clearly distinguish ectopic from Cushing's. Well, it turns out this is the data. These are the percent suppression in our ectopic patients and our Cushing's disease patients. Those numbers are the same. There's no difference, obviously. And so this just basically blew up the whole concept of dexamethasone suppression testing. And yet this was published, we published this in 1997, and yet to this day, and I'm not making this up, the medical students are still taught this. They're still taught this, that this is a valuable test. Now, there was just another publication this month in an endocrine journal from, I think it was an article from a group in India, and they did the same study and had the exact same results. I mean, they have graphs that almost are superimposable in this, like they had discovered something new in 2021 that was published in 1997. I said, oh my goodness, it's amazing. So this test, the high dose dexamethasone suppression test, I think most experts have agreed now that this should be abandoned. So by the end of the 20th century, this was, of course, Dr. Cushing's patient, but this is a Netter drawing in a book from 1995. Pretty much the same, not much had changed in the 20th century. But by the start of the 20th century, 21st century, I should say, it became very obvious that this is not the syndrome I was looking for. Because neoplastic cortisol excess, or neoplastic hypercortisolism, which is what I like to call it, was just as likely to look like this, or this, or this? So we have something completely different than Dr. Cushing described. So we needed more sensitive testing. And Dr. Raff and I came up with salivary cortisol. Now, this is a little bit of just understanding the dynamic nature of the hypothalamic pituitary adrenal axis. And as many as you all know, that this is a very, very old slide. In fact, I can't even find the reference for it. That's why there's no reference for it. I've had this slide for so long, but lights out here. But in the early morning, there's a consistent rise in cortisol level in normal subjects. These are cortisol levels done every 20 minutes throughout the day in 7 normal people. But as you can see, during the day, it's pretty dynamic. It's pretty chaotic during the day in most people. But late at night, there is a nadir of cortisol secretion, which is consistently there in patients who have normal sleep-wake cycles. And by the early 1990s, people in Europe and NIH started to put patients in the hospital, indwelling catheter, and then when they were sleeping at night, they'd come in at midnight and draw serum cortisol. And sure enough, they were able to show that patients who had true Cushing syndrome tended to have cortisol levels higher than what was called pseudo-Cushing syndrome. I like to call this non-neoplastic hypocortisolism. And this was a good test. But this required a hospitalization often in a research center with an indwelling catheter. I said, well, that's not good. That has no practical. You can't do that. I mean, if you go to the Wisconsin State Fair, I mean, you'd have to do almost everybody. It looks like they have Cushing syndrome. So we just said, well, we know we can measure this in the saliva, and patients could certainly collect their saliva samples late at night, and that this had been done certainly in animal research for many years. So we knew that salivary cortisol was in equilibrium with serum-free cortisol. Cortisol, like many other hormones, is bound to proteins, and it's the free component that is biologically active. And it's about 5% of total cortisol is free. And this is independent of salivary flow rates. So we knew that if we collected it late at night and we used a Salivat, a simple thing to collect it, that we could measure it. Now, initially we used, of course, Herschel cooked up a radioimmunoassay, but now we either use tandem mass spec or another immunoassay. And we were able to show by the late 1990s that this test, a simple test that could be done at home, provided pretty good discrimination between normal subjects at 2300 hours, patients with proven Cushing syndrome here, and patients who were referred for Cushing's, but we ruled it out by other means. Now, it wasn't perfect, but it was pretty good. And morning salivary cortisols were no help. And of course, that was already known because cortisol levels in the morning between normals and Cushing syndrome overlap considerably. So this was the first time that we began to realize that this might be a very sensitive means of picking up early Cushing's. And finally, by 2008, it became part of the guidelines for Cushing syndrome, the 3 tests: the urine cortisol, dexamethasone suppression test, which I mentioned, and late night salivary cortisol. But even then, even by the early 2000s, urine cortisol, most people thought this was the gold standard. And that's what I thought until one of our fellows, Dr. Kandambi, this is about 15 or 16 years ago, we put her on a project to look at patients who we had proven Cushing's, who had normal urine cortisols, but clearly had Cushing's, but had just elevations of late night salivary cortisol. And Dr. Kandambi was certainly one of our best fellows. And you know, it's one of the things you need to know is that you always need to be nice to everybody on the way when you're training them, because you never know when they're going to be your boss. And now, of course, Dr. Kandambi is the chief of endocrinology at MCW, and she's my boss. So I'm glad I was nice to her during her fellowship. And she showed that many patients, these are 11 patients, but who had mostly normal urine cortisols, but had consistently, most of them had elevations of late night salivary cortisol and proven Cushing's. And now late night salivary cortisol has clearly become the robust marker of remission after surgery and is superior to urine cortisol for detecting disease recurrence, particularly disease recurrence. So this is widely accepted now around the world as being the test you should do when you suspect Cushing's, and particularly when you suspect a recurrence of Cushing's after pituitary surgery, and it's far superior to urine cortisol. And then the other two people that I have to mention that have really helped me a great deal is a couple of our junior faculty, Ty Carroll and Brad Jaworski, and they're going to step in my shoes as soon as I walk out the door. And they did this study, and just to give you some idea of how robust our Cushing's referral base is, I mean, a lot of people didn't really pay much attention to this, but this is our MCW clinic records. We started there in 2008. This is just like 5 or 6 years. And we had 112 patients who had Cushing's disease undergoing primary therapy. Now, they didn't all have surgery at MCW in those days. Now we have, very fortunately, probably one of the best, will be one of the best pituitary neurosurgeons in the United States in the next 5 or 10 years, who's been with us 4 years now, Nate Swagerman. But I mean, 112 patients in 5 years. I mean, think about that for a few minutes. That's a lot of patients with Cushing's disease in 5 or 6 years. Anyway, 65 of them, we had full data, and 50 had an initial remission, but 15 had a recurrence after their initial remission. And 3 of them had abnormal urine cortisol. 12 had absolutely normal urine cortisol. So in the past, we would have said only 3 people have recurrences, but in fact, there's 15 with recurrences. And we showed convincingly that most of them had abnormal DEX, but not all of them. But all of them had late night salivary cortisols elevated. And the nice thing is that all of these patients had a good response to either redo pituitary surgery, bilateral adrenalectomy, or pharmacotherapy. So we showed very convincingly that these patients deserved some kind of intervention to improve their outcome. So let's go back to this question that I asked about this woman with truncal obesity, diabetes, and hyperlipidemia. Was this really a stupid question? Well, finally, I think about 2016, there was, in my estimation, pretty convincing evidence that it was not such a stupid question. This is a multi-center study done in Spain. And they looked at, by endocrinologists, multiple centers, 353 consecutive patients who had two of four of these things. They either had, or all of them, obese, diabetes with an A1C greater than 7%, hypertension on more than 2 drugs, and polycystic or polycystic ovary syndrome. So they had to have 2 of these 4 things. Now, the reason this is such a great study is they did the 2 tests that I think have the greatest sensitivity, the dexamethasone spread test and late night salivary cortisol. 219 had normal studies, end of workup. 35 patients had both studies abnormal, and 99 had discordant studies, not unusual at all. They repeated them, and 7 of them had consistently abnormal studies. So 42 patients out of 353 had abnormal late night salivary cortisol and DEX suppression. And 26 out of these 42 patients had proven neoplastic hypercortisolism or Cushing's syndrome. 17 had pituitary or Cushing's disease, 3 ectopics, and 6 adrenals, which means that 7.5% of screened patients had neoplastic hypercortisolism. Now, if 7% of this group of patients have Cushing's syndrome or neoplastic hypercortisolism, then I don't think it was such a stupid question. So the other thing that this study didn't even address is the whole concept of mild autonomous cortisol secretion from adrenal nodules. Now, this has just come up in the last maybe 5 to 6, 7 years. And what we know now is adrenal nodule disease is very common. About 3 to 5% of adults have adrenal nodules, and 15, as many as 40% have evidence of what we call mild autonomous cortisol excess. Now, these patients do not have florid symptoms of cortisol excess. The adrenal nodules are usually discovered incidentally. They often have low bone density and fractures consistent with cortisol excess. They often have hypertension on several drugs, metabolic syndrome, sometimes diabetes. And people always question, well, how could they have Cushing's syndrome? I mean, their cortisol levels are just slightly elevated. Well, it's because they've had high cortisol levels for a long time, often 20, 30, or 40 years. And now recent evidence just published this year that this might even be an independent risk factor for a cardiovascular event. And the biochemical features, they have abnormal DEX depression testing. That's the hallmark. They often have low basal ACTH because this is autonomous cortisol secretion, and low DHEAS levels. And sometimes they have increased late night salivary cortisol and cortisol. So this has become, although Cushing's disease has always been thought to be the pituitary Cushing's the most common cause of this syndrome, I think now this is emerging as probably the most as common as pituitary Cushing's. And why is this important? Who cares about this mild cortisol excess? Well, it turns out that we all know that there's a normal range of cortisol, and that the relationship between morbidity and mortality is sort of a U-shaped curve. I mean, certainly if you have low cortisol levels, we know that's not very good. And clearly there's evidence that patients who have overt cortisol excess or Cushing syndrome have increased standard mortality rates and don't do well. But now there's abundant evidence, I mean, 4 or 5 very good studies which show this low-grade cortisol excess is associated with increased cardiovascular events and increased cardiovascular mortality. So that this is a clinically important entity that deserves our attention. And finally, the group of people I've been able to work with at MCW now over the past 12 years of the endocrine surgery group, Doug Evans and Tracy Wang, Sophie Dream, and Tina Yan have just been a delight to work with and do clinical research with. And we showed in this group of patients who have mild cortisol excess that, and one of the hallmarks of whether somebody really has true autonomous cortisol excess is the presence of adrenal insufficiency after you take out the adenoma from the adrenal gland. And it turned out that we do post-op post-op cosentropin tests. We stimulate the adrenal glands with ACTH immediately after surgery, the first morning after surgery, and we can tell whether people have adrenal insufficiency. And it turns out that out of these 22 patients, we just have an article coming out in the Journal of Clinical Endocrinology and Metabolism online and just probably next week, which this is a sort of similar study, but up to 73 patients, and about half the patients need steroids and half don't. So half have adrenal insufficiency and half don't. And the amazing thing, and in fact, I didn't even believe this when I saw it, that you can't tell who they are from the pre-op, pre-surgical testing. I mean, the salivary cortisols weren't different, DEX depression post-DEX cortisols weren't different, the plasma ACTHs weren't different. You can't tell. So the point is that even this patients with mild cortisol excess can still have adrenal insufficiency after we remove that adenoma, suggesting that the cortisol excess was certainly enough. If it was enough to suppress the pituitary adrenal axis, it probably is a cortisol excess affects other organs like the bones, the heart, and skeletal muscle. So what I'm trying to propose now is that this whole concept of endogenous hypercortisolism, which euphemistically is called Cushing syndrome, that term maybe is not the best term, and that we should call this non-neoplastic or pathologic Cushing's, which is usually pituitary Cushing's. And I think it's fine if we call that Cushing's disease because that's exactly what he described. Obviously, ectopic tumors and many forms of adrenal nodule disease. This is very complicated now. Many germline mutations have been found to be associated with benign and malignant adrenal nodule disease. And this is really an emerging area of research. But most importantly, like those salmon swimming upstream, there are many people who have non-neoplastic hypercortisolism, and it's very difficult to distinguish them from patients who may have neoplastic because their phenotypes may be similar. Alcohol-induced hypercortisolism, very common. And Herschel, Dr. Raff has shown that patients with CKD5, a vast majority of them have ACTH-dependent cortisol excess. Neuropsychiatric disorders have been known for 40 years that patients with severe depression have hypercortisolism. Patients with poorly controlled diabetes and the third trimester of pregnancy is a hypercortisolemic state. But there's some patients, like starvation is a cause of cortisol excess. That's usually not hard to distinguish from pathological Cushing's. And critical illness, of course, is a state of chronic cortisol excess, as well as chronic intense exercise. So, and probably many more non-neoplastic causes of cortisol excess that we haven't even discovered yet. So, and our group has also been very involved in the past decade or 8 or 9 years in the evaluation of 3 drugs. Prior to 2012, there were no drugs approved in the United States, or in the world for that matter, for the treatment pharmacotherapy for hypercortisolism. But since 2012, we now have 3 drugs. Mifepristone, which is a glucocorticoid receptor antagonist. We were involved in the phase 3 trial for that, which has been approved. Pasireotide, a drug which is supposed to decrease ACTH secretion, pituitary tumors, and alcildostat, which is kind of like a drug that decreases steroid biosynthesis by blocking the final enzyme in steroid production. And this was just published and approved within the last 2 years. So let's get back to these patients. I mean, this is a woman who had Joe Shaker, my associate, saw with osteoporosis and multiple metatarsal fractures, severe hypertension, and bilateral adrenal nodules, elevated late-night salivary cortisol, abnormal DEX suppression, low ACTH, normal urine cortisol, and had adrenal Cushing's, and had resolution of her hypertension following the adrenal surgery. And this is what she looks like. This man was seen at the University of Chicago in 2000 with hypertension, and he had an elevated urine cortisol, but they thought he had pseudo-Cushing's, non-neoplastic hypercortisolism. He saw us in 2006, and his late-night salivary cortisols were high, his urine cortisol was very high, abnormal DEX suppression, and he had an ACTH screen pituitary tumor removed with a very good outcome. And finally, this woman who was a nurse in Green Bay, fortunately, she was a nurse for an endocrinologist, and she developed hypertension at a young age, and he suspected that she must have a secondary cause, and she had cortisol excess and pituitary Cushing's, and had successful surgery with a very good outcome. So my personal search for Cushing's, the first thing is the Cushing syndrome is a caricature of endogenous hypercortisolism that's really clouded our diagnostic evaluation of this disorder for over 60 years. Neoplastic hypercortisolism is much more common than we thought. It's associated with significant cardiovascular morbidity and mortality, particularly these patients with adrenal nodular disease. This disorder should be considered in patients with a clinical history and physical features of cortisol excess, many patients with a metabolic syndrome, unexplained osteoporosis, and of course, adrenal nodular disease. We feel strongly that the best screening tests are and should focus on late-night salivary cortisol and DEX suppression. And now we have effective surgical and medical therapy for neoplastic hypercortisolism that resulted in much improvement in morbidity and mortality. And finally, the quote that this is an old quote of mine, but this is the one that people reference probably more of all the things I've done. This is probably the thing that I remember the most for is this quote. If you've never missed the diagnosis of Cushing's syndrome or been humbled by trying to establish its cause, you should refer all your patients with suspected hypercortisolism to someone who has. Thank you very much for your attention, and thank you very much for this very nice award.
Thank you, Jay. Any questions for Dr. Findling? Maybe I will have a first question. I know about the salivary cortisol. It's a simple test, but he didn't explain to us how you get it and what do you do with it. And
yeah, I mean, it's as you said, I should have shown a photograph of this. It's a plastic tube. It has a little cotton, almost like a swab or tampon in it. The patient opens the plastic tube and pulls out the cotton swab, chews it at 11 o'clock or puts it in his mouth, gets wet with saliva, and puts it back in, and just puts the cap back on. It remains stable at room temperature for probably 2 weeks. And the patient can bring it back to the lab or actually mail it to the lab We encourage them not to use the U.S. Postal Service to do that, but it's a very valuable test that can be done at home at the patient's convenience. We have discovered it's important to do it at the hour of sleep. One of the problems with when this study started was, they call it midnight salivary cortisol, midnight cortisol. Well, that's because everything came from Europe. Well, at midnight, that's when they start eating. I mean, that's like the middle, it's like, that's when they go to bed. I mean, people in the Midwest, they go to bed. You ask people when they go to bed, it's shocking what you hear. So, I mean, 8 o'clock, 9 o'clock, they're in bed. We found that hour of sleep, if they have a consistent hour of sleep, even if it's 9 o'clock in the evening, if that's their consistent hour of sleep, their circadian rhythm has learned that, and that's the time you should do the sampling. You don't have to keep the patient up at 11. Now, we've had patients that had false positive results because what they do is they usually go to bed at 8. So they go to bed at 8, they set their alarm to get up at 11 to do the sampling. Well, there's something called the cortisol awakening response. So when you wake up, there's a surge of cortisol, regardless of what time of the day it is. And so that probably causes false positive results. So we've learned in some recent studies that we published that hour of sleep, if it's consistent, is when you should do this test. And in the United States, midnight is, very rare do you find patients who consistently go to bed around midnight.
So, Jay, are sleep disorders then a potential cause of hypercortisolism, endogenous?
Yeah, that's a very good question. It's been studied. The studies we've done have not showed much elevations of late night salivary cortisol, but of course we're doing them late at night. Whether they cause hypercortisolism, there is speculation in some studies that there may be some mild aberrations of cortisol secretion, but it's not very consistent. And although obstructive sleep apnea is very common in patients with true pathologic neoplastic hypercortisolism, many of them have obstructive sleep apnea, but they have the phenotype. They have obesity, hypertension. So it's not surprising there's a high prevalence of sleep apnea in that group of patients. But whether sleep apnea as a primary disorder causes significant cortisol excess, they do not have, their dexamethasone suppression testing is usually normal, and their late night salivary cortisols, at least in our studies that I haven't done, but Herschel did with some of the pulmonary people, have not been consistently elevated. So although it's often a feature of cortisol excess, sleep apnea per se does not seem to be a major cause of hypercortisolism.
Can I ask another question? I'm sorry.
Sure.
Else. What I didn't follow completely is why the patients after adrenal surgery are you talking about just removal of a nodule?
Yeah, yes. Well, I didn't explain that very well. So when you have a cortisol-producing adrenal tumor, an adenoma, or carcinoma, but certainly an adenoma, and you take it out, the patient should have, if they've had significant cortisol excess, many of them will have adrenal insufficiency because they've had low basal ACTH levels because they've had autonomous cortisol secretion, that is independent of ACTH. So their basal ACTH levels are low. So the other adrenal gland is functionally not terribly incapacitated, but at least is underactive. And so when you take out this cortisol producing adenoma, the other adrenal gland may not respond appropriately right away. Now it will generally recover pretty quickly, but you may have a state of hypocortisolemia, adrenal insufficiency, for a period of time. And we probe that by doing a stimulation test the first day after surgery, and we can tell with great clarity whether somebody has adrenal insufficiency post-op and is going to need glucocorticoid support at discharge, or whether they don't need it at all. And what was surprising when we did this study, and again we've extended it to over 70 patients now, is that we can't predict which patients, based on pre-op testing, are going to have adrenal insufficiency and which are not. So even some patients with very mild cortisol excess have adrenal insufficiency post-op, and some with fairly significant cortisol excess do not. So I think it's, and that is, I think, pretty new and very surprising. It'll be interesting to see what the response of the endocrine community is to these findings. It's not what anyone would have predicted. I mean, I think that's certainly not what I would have predicted. But I think it just amplifies the importance of mild cortisol excess, that even mild cortisol excess over a long period of time. I mean, it's like taking prednisone 5 milligrams a day for 30 years. Well, nobody's going to do that study. I mean, a placebo-controlled study of taking prednisone 5 milligrams, which group would you want to be in? The group with placebo or the group taking 5 milligrams of prednisone for 30 years? I mean, I don't think it's not a toss-up. So the point is, mild cortisol excess over an extended period of time translates into, metabolic bone disease, hypertension, probably impaired glucose tolerance or frank diabetes, and occasionally even neurocognitive dysfunction. So I think this is an important clinical entity which certainly deserves close scrutiny and when necessary, surgical intervention.
As we see in the transplant recipients.
Exactly.
Jay, I was wondering, after the adrenal surgery, you said they develop adrenal insufficiency, and you do a ACTH stimulation test that will tell you whether the adrenal is responding. But at the same time, pituitary can also have been suppressed for a long time with the cortisol. So how do you know pituitary has come back?
Well, we measure ACTH levels too. I mean, we know if the cortisol levels are low, obviously the pituitary hasn't come back. I mean, obviously they have low ACTH levels post-op. And most of these patients recover pretty quickly, usually within 3 months, sometimes longer, but usually within 3 months. And so we measure ACTH and cortisol the morning after. And the way we just say, if the cortisol level is less than 5 in the morning, or they have an impaired cortisol response to stimulation with ACTH, we say that that's adrenal insufficiency and they go home on steroids. We test them usually within 4 to 6 weeks post-op, and many of them, even within 6 weeks post-op, have completely normal adrenal function. So they don't need extended glucocorticoid support. But this is a kind of a unique approach to this problem. In the old days, everybody got steroids. I mean, everybody just got discharged on steroids thinking that everybody needed them, but it turns out some do not. And unfortunately, we can't tell based on preoperative testing which ones are going to need steroids and which ones are not. So we just have to test everybody and provide cortisone to those who clearly have adrenal insufficiency post-op.
Jay, very nice talk. Are the
Thank you.
radiologists able to help at all in terms of differentiating these adrenal nodules?
Yes, they are. I mean, adrenal nodules are common in, the many causes of adrenal nodular disease, but the vast majority of them are benign cortical adenomas. In the past, they just got blown off because they just said, oh, this is, a 2.3 centimeter left adrenal nodule. It was present in 2007. It's benign. Thank you. But the problem is, yes, it's benign. And you can tell based on attenuation values or something called Hounsfield units, you can clearly identify benign from malignant, both based on attenuation values or Hounsfield unit and size. But they were just blown off. And yet, they in 2007, so they've had cortisol excess. They have hypertension, they have obesity, they have diabetes, and they have low bone density with vertebral compression fractures. They've had high cortisol. Yeah, it's benign. It's definitely benign, but it's not benign physiologically. And so these patients it needs to be evaluated. And when present, I think treated, in our opinion, aggressively with surgery. But I think, in fact, now it's amazing what's happened because it freighted about a year ago. maybe even less than a year ago, the radiologists now have a dot phrase they put in when they find adrenal nodule, which says, these patients can have, metabolic derangements, obviously, PHEOs, aldosterone, et cetera, and they need to have an endocrine evaluation. And so, so now we have an adrenal clinic, a dedicated adrenal clinic and a lot of these patients now just get referred to the adrenal clinic. But prior to that dot phrase from the radiologist, maybe I'd, we'd have an adrenal clinic, maybe I'd see 1 or 2 adrenal nodules a week. Now, every time we have adrenal clinic, it's 4 or 5 new adrenal nodules. So it really has made a difference in sort of getting this sorted out and finding patients who may benefit from therapy. So it's made a big difference how the radiologist report looks. Because in the past, when the primary care physician got this, they just said, oh, it's a benign, don't worry about it. You have a nodule in your adrenal gland. It's been stable for the past 10 years. Well, they're right. It's been stable, but it's been making too much cortisol for 10 years.
Okay. Any other questions?
There is a question in the chat regarding LNSC. Are you still recommending 2 samples on non-consecutive days?
Yes, we generally do 2 samples on usually on consecutive days, actually. We don't care if they're consecutive. We tell the patient to do consecutive days just so they can remember to do it. But if they're doing something else one night, do it on a quiet evening at home, not during a Bucks game. When it's sort of interesting, when we started doing salivary cortisols back in the 90s, we had a control group, and the control group, this is a true story. This was a group of nurses that were watching a Packers game on a Sunday night, I think. It doesn't matter what night it was. And so we had them do salivary cortisols after the Packers game. And there was some alcohol involved in this, I think. And some of them had elevated late night salivary cortisol. So it's not surprisingly that if you have stress at night, you're going to have, the test is sensitive, but there's going to be some problems with specificity because of proximal stress that people may have late at night. So you need to do it in a quiet evening at home to get satisfactory and accurate measurements. But consecutive nights are fine. We just do it consecutive nights. We usually just do 2 samples. I mean, because I think the dynamic nature of the HPA axis and the variability of cortisol secretion, even in patients with true Cushing syndrome, let alone patients who have non-neoplastic hypercortisolism, we recommend 2 samples. And
okay.
Thanks everyone for all the nice comments, by the way. So
thanks for the lecture. Really instructive. Thank you very much.
My pleasure. And thank you again, Cobb, and for the Academy for this very nice award.
Thank you very, very much for your wonderful talk.
My pleasure.